There are a few more women who are going to join us this morning, but we will slowly begin as I want to share things, but I also really, really, really want to hear from you. So I thought to first off share that some of the thoughts that went through my head this morning, and I was prepping and I was thinking, I wrote them down because I was like, whoa, where is this coming from? I wrote down, oh, thank you, Dina. I wrote down, is what I'm doing okay? Do people want me to share what I'm going to share? Have I done anything wrong? Is what I've been asked and decided to create for and with women okay? And most classically, the thought or the question, will I be burned? came running through my head. And the next louder voice in my head said, breathe deeply and serve, because that's what I'm here to do. So I wanted to share that to just thank you each for joining me. And thank you for your interest, your curiosity, your service that you offer or will offer women, because it's needed and it's cherished. So yeah, that was just I wanted to share that. That's where I started this morning. And I was like, okay, now we get to it. So a little introduction. OneStep is a program that I created to fill in the gaps in what I see in modern birth work. The program begins with a pretty thick self-assessment and reflection, which some of you may know can be very revealing. We talk about principles of traditional birth work, client creation, and business development. And the body of knowledge, I believe, is useful for birth workers in any setting, so medical or traditional, because it offers a foundation from which we can all really listen to what women are needing. So I think that's really the crux of what OneStep is and what it is being created for, something for the now, something for the future. So in today's session, we are going to explore the fundamental, extremely distinguished differences between medical midwifery and medical practice of birth and traditional birth support work. So just by a show of hands, how many of you know the difference already? I can put my hand up. Kind of, yeah. Okay, great. So what we're going to do is we're going to explore and reveal to the world, to each other, some pretty distinct definitions. I'm going to screen share. I'm going to screen share what is out there, what we can even offer clients so that they can understand. Can you see this where my mouse is swirling around? Great. So here, this is from my own advocacy website. Here is I'm going to zoom this in a bit so we can really read it. Here is the definition of a medically licensed midwife from the BC College of Nurses and Midwifery, which is what the sort of the ruling body of midwifery and nurse practice in British Columbia. So a medical licensed midwife is, quote, a licensed professional who provides primary care to clients and babies during pregnancy, labor, birth, and the postpartum period. As primary care providers, midwives may be the first point of entry to perinatal services and are fully responsible for clinical decisions and the management of care within their scope of practice. If you'd like to go deeper, there are links that they actually provide, like this is a hyperlink. A midwife completes a 4-year university program that covers a wide variety of subjects related to midwifery, ethics, and clinical skills. After graduating and before being granted practicing registration with the BC College of Nurses and Midwives, a national exam must be completed. In BC, only midwives who are registered with BCCNM can call themselves, quote, midwives or, quote, registered midwives. To learn more about midwifery, visit the Midwives Association of BC. So that is the straight up, that's the definition of what a medical midwife creates for her clients. Some key words that I want to point out before we move on is this one. Oops, can I highlight this? Yeah. Labor. This right here. And especially this. This part here. We know that they have to be licensed with the College of Nurses. And this right here. So it's just some things that I want you to kind of keep in your mind as we move along. A really important thing that we need to recognize as well is that midwives are under regulations by the government. This is going to get a little bit boring because sometimes government stuff is it's a little boring, but I think it's really important that if and as whether we're doulas or practicing in the medical realm, doesn't matter. People have to follow these particular regulations. Either as a midwife, they need to follow them because that's what they must do, or as a traditional birth support worker, we don't want to do these things. And not only that, as a woman trying to figure out her options in care, and this is where, as a support worker, no matter what our setting is, we want women to be aware of what kind of care they're receiving and what they're being given. We don't want women to get into situations where, say, someone is actually doing these things. So the things I want to point out in here, you're welcome to, I will actually drop the link in our chat box if I can figure out how to do that. Here's that one. This is a really great resource for clients. And let's take that away. There we go. So there's a bunch of vocabulary words, which is helpful. We keep going down. This is the part that I really want to explore and highlight. Restricted activities. It's funny that they call it restricted because it's actually like allowable activities, but I believe they mean restricted in the sense that this is what no one else can do. So make a diagnosis. So midwives can make diagnoses. Anyone else in the scope of birth care cannot. That includes your doula, that includes your traditional birth support worker, your husband, like nobody else can make diagnoses. Perform procedures on tissue below the dermis. I love how super medical this is. It's great. The mucous membrane, which I didn't even look it up. I'm pretty sure it's skin. So performing episiotomies, repairing episiotomies, taking swabs, these are all, we can all recognize these as extremely clinical acts. Again, insert acupuncture needles under the skin for the purpose of pain relief during labor or postpartum period. I think it's wild that I'm not sure if they include drugs. Yeah, here we go. So acupuncture needles. So a midwife can do acupuncture needles. blood sample, wound care, administering of substance. This is really important. Nobody else can administer drugs. I personally am so fine with that. I don't even want to. I don't know why anyone would try to. Um, these are the purposes that a midwife would be doing that. This is a key one that people don't necessarily recognize or practice, which I believe is potentially a cause for some confusion and a little bit of stepping over boundaries. So, putting an instrument or hand or finger is reserved for medical midwives. This actually also applies to your partner, to the partner of the person. They actually can't legally do, say, a cervical check, um, which is what it is. This is even here, suctioning a newborn, um, beyond the labia majora. So he has internal vaginal exams, vacuum assistance. This is the very medical perspective of what they're creating, the service they're creating for women. Anal verges, so perineal repairs, anything up the bum. Here's a great one. Midwives are the only practitioners who are allowed to manage labor or normal spontaneous vaginal delivery of a baby. The keywords here are manage and labor. And we'll talk about the distinction between management and support in a bit, but something to kind of just jot that down and remember that one. Ultrasound for purpose of fetal heart monitoring. Instruction to apply it. Application of ultrasound, as far as I understand, is not just the ultrasound itself, but like they're reading the ultrasounds. They're the ones who actually understand what they mean. They're trained to see and read. And as they're moving their devices around, they're using tools, clinical tools, to create those, again, diagnoses. Dispense drugs. Here's we're back to the drugs. So no, you can't give drugs out, but midwives can. So there's a bunch of, I have never read the drug schedules regulation because it's not something that applies to me, but one could. This is interesting here. So it says here, only a registrant may provide a service that includes the performance of an activity set out in subsection 1. So this is everything above. Only a registrant, that is a legally registered practicing medical midwife, can provide any of the services that are listed above, except it doesn't apply to an Indigenous person who's practiced Indigenous midwifery prior to this date, which is fascinating because I'm not quite sure of the date when midwifery became a part of the medical body, but I think that's very close. I know we're very young in British Columbia. So that's an interesting one to kind of put in the back of the mind. I have questions myself of like, why? Why not now? Why not? What is going on up here in these services where uh, an Indigenous person would be practicing, like, are they also licensed medically, or is that the exception? And is it only, it's an interesting one. So yeah, I think the most important things here are really about recognizing and making sure that clients recognize that if they want medical management of their birth, this is a great service. And them recognizing what management means. And also, if you come across someone or you yourself are creating space for traditional birth support work, or you're a doula supporting in traditional birth support work, recognizing that these things here should not be in those places. Okay, that's really, really important. That's why I wanted to share this part. Because we're just going to rip through this today. This is I feel like it's a very short session. If you do have any questions that come up and you feel like sharing them with the group, for now, feel invited to just jot them down in the chat so we can all kind of be able to use them. If we don't get to all of them, we can all use them for our own personal reflection. So I want to get to the exciting part, which is where we get to define traditional birth support work and what it looks like, how it is different, how it is so different, and also really highlighting that it is not something that stands against, it is something that stands beside, and it is also something that I believe is absolutely able to serve that medical setting. It's just period, end of sentence. So a TBSW, a traditional birth support worker, is not a licensed medical professional. Thusly does not, and we just went over a bunch of these, does not offer perinatal services. This is a clinical These are clinical services. Remember, the midwife is one who is first point of entry to perinatal services. So perinatal services are about blood work and urine tests and things like that. So a traditional birth support worker does not offer perinatal service, isn't even a point of entry. That person cannot be the person that reads an ultrasound and understands what any of those codes mean at all. She can't even go and tell you to go get one. That's not that person's role. Cannot make clinical decisions and cannot manage care. So management support, the biggest difference, and we could go deeply into this, but for now, the biggest difference to remember between management and support is that it's really about the woman. In a managed care setting, you have people managing your birth experience for you. In a support setting, you are the manager. So, for example, if you, as your own manager, decide that you would like perinatal services, a traditional birth support worker can support you by offering you resources of where you can go and find those perinatal services. She can also support you in hosting a conversation with you once you've received the opinion of medical practitioners about those services that you get. She can host a conversation with you about what you think and how you feel and how you're choosing to trust or deal, or how you're choosing to apply those services and the knowledge you've gleaned to your own management of your care. So that's really the basic difference in basicness. we're doing a skimming of basicness. So we're just going to keep on going and then we'll open it up. A TBSW does not complete centralized training. There is no such thing as a central body of regulatory training for traditional birth support work. I will offer that let's say, the body of wisdom, the great body of wisdom, has been created and shared woman to woman to woman to woman to woman for time immemorial, thousands, tens of thousands years. So that's sort of that's the centralizedness of it, is that it is everywhere. It is available to anyone. It's available to men. It's available to anyone. We want to know about how to support women through birth. That's available to anyone. And she may come to her work in a variety of pathways, including personal experience, here we go, lineage, Indigenous knowledge, apprenticeship, and a variety of programs offered globally. So there's quite a few programs out there. I've heard of WAPIO is one of them. There's Now I'm going to, of course, forget them all. There's beautiful two women who work out of the States. Um, and I'll see if I can, maybe that's something I'm just now realizing I should just put that here as a link. And I will do that. She does not complete an exam, nor does she call herself or refer to herself as a quote, midwife or registered midwife. This is really important. This is a great big fat distinction. It's also in a lot of circles an issue of contention. It's touchy that a word can be a part of a regulated understanding, but this is the way it is in British Columbia right now, and it's really important for us all to create that truth. There are other words that we can use to describe a very different form of care than what these words currently describe. She also may not or does not choose to offer any of the clinical practices listed below according to the law in British Columbia. So we kind of went through them in the midwives regulations, but this is what I will tell women who are seeking traditional birth support work. These three things, this is how it either isn't happening or this is how it is different. Okay, so the first one is performing internal vaginal exams. I love sharing this with women. It's a test created by a dude in the 1500s who wanted to stick his fingers up girls' vaginas. So I'm sorry, but anybody who feels that that's something that they would like to also do in a traditional birth support setting, I just, for me personally, it doesn't compute. Um, it is a direct line into medical practice. These are some reasons why it's not great. And you can tell these things to a woman. Like, again, these elements of principles and tenets and philosophy and ethics, we can use this in any setting for advocacy and awareness. A woman's going to have the right to make a choice and a decision about her care. Tell her, just so you know, that vaginal exam that someone's offering you could create bacterial infection. And sometimes I even say this to people. Why put anything into a place where everything's coming out? Deliver the baby. So, delivery of a baby is specifically refers to the medical delivery of a baby where the baby is being essentially medically in a clinical setting inspected for a series of things that you can write on a chart. It's called AGPAR. That's something that's still used. Um, that is a clinical practice. So traditional birth support work settings, that is not what's going on. Um, the mother is the manager. The father is the manager. If hands get involved, it's because a mother or father's hands physically cannot. And those hands are being asked to support bringing that baby right to mommy's skin. And it is the mother and it is the father who take on that. Remember that word, that responsibility of management? It is the mother and father who take on that responsibility. And you know what? Mothers and fathers could advocate for that in a medical setting as well, that they are capable and they're okay with taking on the responsibility of looking at their baby for the first time and figuring out if they're doing well. Because that's what we are born with an ability to do. And if we're open in that way, we have that right. And the last one is administer medicines, pharmaceuticals, injections, nor perform any clinical tests, requisitions, or procedures. We kind of spoke about this before. No traditional birth support worker should ever be offering women this, period. And medicines, pharmaceuticals, injections, tests, requisitions, procedures are also elements that a medical support worker, like someone working in the medical management system, like a doula or even like a friend even, you could provide space for conversations about consequences, the risks and the benefits, depending on what's going on for the woman, so that she can make her choices with feeling very informed and feeling very much empowered in her agency to make those choices. So that is the Layla rant. That's the bulk. And I believe that understanding these distinctions, I'm going to unshare this screen. Share. Hi. So understanding these distinctions is really what is going to give us all an ability to create the kind of service that women really are asking for in all and any settings, really deeply understanding the difference and recognizing that each woman has the right to know. She has the right to know the difference. She has the right to know her options. She has a right to know the consequences in an actual objective point of view. So I would like to open this up a bit for discussion. So. From your perspective, how are both, I want us to see, again, this isn't about against, this is about for, okay? So I want us to all see what's great about medical midwifery, what's great about traditional birth support work. So welcome to just flag me or raise your hand. You can think about it for a minute if you need to. I want to know, I want you to tell me and everyone what you see as great about midwifery work and what you see as great about traditional birth support.
I don't know how to put my hand up anymore. Where is it?
Great.
I don't
It's
know where
like,
it is.
yo.
I could just put my hand up. I I appreciate you breaking this down, and I do really love that there is just this very clear boundary. It's very clear to me, and I think um, as someone that's trying to access care, they can see how both can fit and work really well together as a team and who does what, and they can find safety in that. So who do I go for this? Who do I go for that? Right. And then it just fills everyone's need for care. Right. I think it's really lovely. So I appreciate that there is this clear boundary that should not be up for, yeah, it should be very clear for everybody. So that's what I think. And I'll
Thank
just
you.
put my hand up like this.
Yeah, sounds great. We can all do that. I love that. I don't even like those little orange, yellow, like weird
I don't know where it is.
cartoon. Yeah, Jennifer.
I really think that there is a place for both, and there is obviously a need for some medical intervention sometimes. So having that option is really important, and not having to go to like a medical doctor, like the in between of a midwife, is super valuable. So, but I really love how you just laid that all out. Like, perfect.
Thank you. And thanks for sharing. Yeah, the value in both, right? Yes, ma'am, Amanda.
I love what you said about that it kind of boils down to the midwife is pretty much responsible for the entire management of how the labor goes and everything. Um, and then that's really helpful for me, like to kind of like break it down, like where the mother is responsible in a traditional setting.
Beautiful. So really highlighting the distinction of where responsibility lies.
Mhm.
And just out of curiosity, how do you think that can, like, we can make that distinction really clear? How do you think responsibility shows up for sort of the vice versa? How do you think responsibility shows up for a birthing woman in a medical midwifery setting? How do you think responsibility shows up for the traditional birth support worker? How would we kind of create that?
Well, like I guess like in my experience, like I went with like a clinical midwives and I also had like a birth plan that if I had known this before, um, it would have been more, I wouldn't have been so surprised in my birth, but it's like they informed me of what was going on and but didn't really word it like as if I had a choice. So I think like it sort of shows up as being coerced a little bit because if they're responsible for your birth and they're responsible for like their own like registration as well, then they're kind of like wording things in a way that like um mind you, I was like in such a state that I wasn't like I was just like, yeah, sure, whatever, like, whatever you think is best kind of thing. But it would have been so amazing if, like, in a traditional setting, if they were like, how are you feeling right now? Like, do you feel safe? Do you feel comfortable? Versus like, it's been 1 hour, and if one more hour goes by, then this and this and this could happen. It's like, it's, I don't know if that answers your question, but um,
I think I hear you. Like it's almost, and I wonder, like, can a woman then in a medical midwifery setting be encouraged to embody and embrace her responsibility in her process? Can a traditional birth support worker be encouraged to embrace, can we all be encouraged to embrace responsibility, you know? Or does it have to be so starkly, um, eh, you know, the midwives are completely responsible for managing? Well, yeah, if that's what we're saying, then it does set up a situation like you described where you feel like, okay, well, whatever you say, and then there is a sense of disempowerment, vice versa. If you're in a traditional birth support setting and the traditional birth support worker is like, well, I have no responsibility here. It's like, well, so really the key there to me is responsibility, everyone. Now we get to the next part, management support, right? That's kind of what I'm it's kind of what I'm pointing to. So absolutely, Amanda, like you're describing essentially what um, the gap. You're describing the gap. Your experience had a gap because nobody sat there telling you it's okay to be responsible. It's okay to like embrace that and embody that. Like as if we're not even encouraged to be responsible for how we eat. Like the amount of ease that it takes me to like I could just go, I don't, but like I used to. Like it'd be like and W freaking all day long. Like it's right there. I don't have to be responsible for what I'm putting in my mouth. Actually, you be responsible. Now you catch the fallout and you make all the decisions because of so anyways, thank you. Thank you, Amanda. Bang on. And thank you for revealing that experience. Anyone else? Oh,
Um, I was just wondering how it plays out if there's any overlap in the case of like an emergency, if you're supporting a birth where there's an emergency.
so you talking about in a medical setting where there's emergency?
No, in like a traditional setting, if an emergency happens in a birth.
Ah,
Like,
this is an interesting thing that you bring up because believe it or not, the word emergency belongs to the medical paradigm of birth. And that's big, and that's a big discussion. And I can tell you from my experience that when um, a situation arose where there were choices and decisions with consequences, very real consequences in both ways, and those choices and decisions and the consequences of them were something that need to be talked about. And the decision to, say, integrate medical management into a traditional birth support setting is made or not made by the birthing woman and partner upon being informed by the traditional support worker of the consequences. And consequence, I say that, I don't mean always bad. Consequence is just, to me, an objective word. There are good consequences and there are bad consequences. And every choice and decision that we ever make in life, that we each ever make in life. You know, I have a glass of water. The consequences of me drinking this glass of water, the good ones are that I will be hydrated. The bad ones is that if I drink this whole thing right now, I might have to get up and go pee and waste 5 minutes of your time. You know. But I love that question, and that's a much deeper exploration. And it is to say, then if we link that back to responsibility, it is absolutely in both people's responsibility to be informing and making choices and decisions. So how can a traditional birth support worker be responsible? Well, when she's responsible in her attention, in her uh, in her listening to what the woman and the man are saying. Is she making a diagnosis? No. Remember, that's the clinical setting. So there's no diagnosis being made. Is she listening and watching and observing? And if there is, for example, a woman saying something like, my baby isn't breathing, what can she be informed of? Here are your options. Here are the real consequences. Things like a baby's attached to that umbilical cord and is currently getting oxygen. If you feel the need to bring in medical support for infant resuscitation, this would be the time to call because we're 45 minutes out of town. It's going to take the ambulance a bit to get here. If you would like to wait, that is also your choice. Here are the consequences. The good ones are baby might wake up like 90 whatever percent of the time. Bad consequences, the longer you wait if baby needs help, brain damage. That is a woman's right to know that those are the different things that she can choose. Yeah. That's like I'm so grateful that you brought that up, Amber. That's like a massive conversation, and I've had many of them when it comes to like, what is emergency really? You know? So that's something I would highly recommend exploring that a little bit more. What is emergency to you in your life? How do you, as a human being on this earth, handle your own wellness? You know, when do you call medical care? What is that boundary? What is that limit? It's a really good one. Thank you. I'm going to move on to another little, because oh my gosh, see how fast this goes? This was so short, but I'm so grateful to each of you. I want to pull up, because we did actually get through. Okay, kind of pushing a little bit deeper to how are and really letting, again, we want to be for both of these paradigms of knowledge, these distinct paradigms of knowledge. How could you see them each as useful? And at least kind of pointed at this too. How can you see them as useful for clients, both of them? How could you see it useful? Maybe an example of a situation where a thought up situation or something you've experienced where both of these services are helpful. Yeah.
I have one that I will share
Thank
that
you.
just came to mind as an experience that I had recently of an unintended and I was there as a traditional support worker for this family, and um they had midwifery care, lovely midwifery care, and their intention was to deliver at the hospital, and that was their choice, and they felt really great about it, but they didn't quite make it there. And everything was beautiful in their birth. It was lovely. It was great. It was fine. It was all great. And it was their choice to go to the hospital after to check on their baby, just to ensure that everything was great. And in this particular scenario, their baby needed additional support that they couldn't have seen outside. They they had the knowledge of genetic history on their side. They knew these things came up, and so they had that information and support medically throughout their pregnancy to point to that as possibly being something that they need to check out. And so they decided to take their baby and check, and it ended up being something that they really needed to do. And so they had the support, being to have a traditional support worker at their house, so they felt supported in their choices at home, um, for the birth of their baby, and then they felt comfortable enough with their care to go to the hospital to get that additional check-in on their baby, which they ended up needing, and it was a beautiful thing. So they had that wraparound care and that support, and there wasn't fear there. It was great, right? They just ended up getting the best of both things, I think, in that scenario. So that's what came to mind with me. I think that was an easy one, where everyone worked really well together to make sure that everyone felt, yeah, that they could approach their birth without fear, and they could just lean into everyone and their expertise. And I think that's what's important at the end, right? Is to
Yes.
be to be responsible and intuitive into yourself as a parent to make that choice. So that's what came to mind. Yeah.
I love that. Thank you so much, Elise. And you pointed,
Yeah, of course.
yeah, you pointed exactly to this piece. You said, that these folks felt really great about their choices.
Mhm.
That is key. Like sometimes the best service that I have created for a family is, you know what, your choices seem like you actually want this. I become completely out of the picture. I don't care. My best support is like you need to feel empowered and with full agency over the choices that you're creating. You need to understand. Again, I love that you're demonstrating, those feeling responsible about informing of the consequences, so good and bad, and the clients feeling informed of them. They created a space in their world where they felt that they needed a particular service to understand the choices they wanted to make. And I would offer that often when we speak of choices, we say this one little push that I'm going to do. We say the word need.
Mm.
And I
Mhm.
think one of the most difficult things as a birth worker is to recognize when we say need, are we saying because the end story was what we all want it to be? Perfect, living, healthy babies. I'm not saying that we don't need that. We do. That's great. That's fabulous. From a birth work perspective, it is always the client's choice. And that's sometimes forgotten, that if they decided, for example, that even with the body of knowledge that they had created for themselves, that they were going to face and carry forward and nourish a child. I'm not sure of the issues, but let's say, heaven forbid, something that created either morbidity or infant mortality, in a child. Um, if they're being given the agency to be responsible and to understand their choices, that's okay.
Absolutely.
You know?
Absolutely. Absolutely. That takes so much. That takes so much holding and having intuition and sometimes yeah, that's the piece I think that's really missing and unfortunately we're trying to collaborate so that they can fill that hole, right? That going into their self and their responsibility and yeah,
Yeah.
that's the part that we need to
Those are the little gaps.
that's
Those are
it. That's
the
it. The
yummy.
big ones, right? And we get there.
It's huge.
What a
Anyone.
profound thing.
Thank you so much for sharing, Elise, and being so clear with your story. And thank you for also receiving that little, nudge. Those are the little tiny gap bits that we need to collectively, like you're saying, collaboratively, collectively work to debunk them, reveal them, get over them, and how do we move forward? Because here's today, we've got all these bodies of knowledge crisscrossing with each other. How do we do this? So thank you for revealing that. We unfortunately have 10 minutes left, so unless somebody has a pressing answer to how are these or an experience of how are these paradigms useful, I for both paradigms useful for clients, I would like to look at the questions. Although for some reason I can't see them. Aha, here we go. Let me fish out some questions that we got on our chat. Oh, thank you, Dina, for clearing up the mucous membranes are moist. Yum. So not just skin on the outside, skin on the inside, as I guess the injections of drugs and things would be about. But I guess you are, oh yeah, because you're going through the skin and into the moist parts. Cool. Thank you for that. Um, only on reserve too. Elise, was that about the that regulation in the
Yeah, in 1995. So prior
oh
to 1995, and it said in the language, it's only on reserve birth. So
ah
off reserve midwives, traditional indigenous midwives wouldn't apply. It's only for birth on reserve, which is
interesting.
interesting.
Yeah,
Very
totally.
interesting.
Thank you
Yeah.
for that. Amanda, so do these rules apply only in a clinical setting or even in a free birth setting? For example, could a husband get in trouble for helping his wife give birth at home, for example, if he did a cervical check? That's a fantastic question, and it's not an uncommon one. So I'm just going to open that up. What do we think? Do these rules, now that you know what these regulations are, and what a clinical setting is and what a free birth setting is, can a husband get in trouble? How could he get in trouble? Could he? Now I see a no.
Like if a neighbor like called someone and said like, tried to get like, I don't know.
I love that. You, you stuck your husband's, that man stuck his fingers in you. And I don't know. Yeah, I mean, I think I think the thing that I want to pull out of this is like, why do people feel like they're gonna get in trouble? Period. Why are we in a world where we, even like what I revealed at the very beginning, where I was like, I'm about to prepare for this call, and I'm like, am I gonna get in trouble for this? Why? Who is gonna get who in trouble? You know? Um, the key here too is we need to talk about, again, cervical exams, not in this moment, but that would be what in a traditional birth setting, and in a clinical setting, here comes the capacity of a traditional birth support worker to offer the wisdom of like, that was invented in the 1500s. Here are the consequences. Everybody's hands are a different size. Mine are super tiny. My centimeters are, how are they the same? I mean, I can't even do as big as like, I don't know, that's a lot bigger. I don't know. Plus, we're also presuming the medical body of knowledge, which says that 10 centimeters is the thing, the only amount that a woman can be. There's research out there, current research, that says a woman can be 6 centimeters, a woman can be 12 centimeters. So even that is, there's a range. Plus, are we not then diagnosing? Are we not supposed to be diagnosing in that if, you know, what we're saying is in the unassisted or free birth setting? You know, is the husband supposed to be diagnosing? Well, let's say, for example, he does. He puts his hands in there and he goes like this. What what about the consequences? What if bacteria gets in there? She spikes a fever. That's a that's like God, that's a whole bunch of crap. And then they got to go in and explain what's going on. And then there's all these medic. Okay, that's one option. Um, so is it like, is he getting in trouble? I don't know, but what are the consequences of that act? And we can describe that, you know. Plus, why does a woman want to know, you know?
And I just like, because that was like, I think that was a bad example of like the cervical check in particular.
Mm.
But like, I mean, like, I guess my broader question is like, is free birth like given the list you gave us of like what a registered midwife is free birth then like illegal? Like,
Are you
I
saying
guess
I didn't quite hear you saying a legal or illegal?
illegal.
Is free birth illegal? Is that the question?
Yeah. Yeah.
Are you smiling because you know the answer?
No, I'm smiling because like I don't know. I don't know if I'm asking like a really silly question, I
No
guess.
question.
Like
No question is silly. You are asking a perfect question, and people need to know the answer.
like
No,
I guess
free birth is not illegal.
like it's not maybe like not so much the husband, but I shouldn't have said that. It's more like if you were there, like if a traditional birth worker was there. And then I think we talked about this before, but like if someone's acting as a midwife, then they can get in trouble. Like
Oh,
if,
here's the distinction though. Careful, Amanda. If somebody is acting as a midwife, they are a registered medical licensed practitioner. Period. Done. You cannot act as a midwife. Because why? Because now remember the definition of midwife: someone who diagnoses, someone who offers clinical care, someone who offers drugs, someone. So when you look back at what the definition of the medical midwife is, a traditional birth support worker is something that is none of those things.
yeah, I hear you. Like you don't want to be doing any of those things anyway.
You don't
Re-
have the license. You don't have the 4 years of education training. You don't have the knowledge. Did you know that if you wrongfully put an injection into someone, you could pop an oxygen bubble into someone's bloodstream? And that is freaking bad. You do not, traditional birth support work knowledge is not medical. It is
Mhm.
not of a body of clinical practice. So is it illegal for a person to call themselves a midwife and to practice midwifery, quote unquote, the word midwifery, in a what would otherwise look like an unassisted home birth? They are not a registrant, they are not a licensed practitioner. Is that illegal? Yes, 100% illegal. You may not do that. Nobody can do that. And actually, awareness for women seeking care, that is dangerous because you're being diagnosed, you're being treated with some concept of crap that like is they're not registered to give that. That's like, for example, it's like a person being like, I'm an engineer, I'll build your bridge. How do I what? How do I know that this what? So that's illegal. But what is completely within a woman's right is to bring into her traditional birth setting or medical clinical setting, actually, someone who is a traditional birth support worker who is offering support-based management, conversation space to inform a woman about her decisions she might make, love, relationships built on trust, tenderness, gentleness, a cup of water. Think after this call, write down a list of things. Look at that medical list, write down everything that's not there. That's what a legal traditional birth support working person can do legally. Everything that's and guess what? That's actually what it is. It's perfect. That's why I wanted to really distinguish it because it's makes it really clear. Like, right, okay, so I can massage a woman, but I can't do acupuncture. Great. I don't want to personally, I don't want to poke women with freaking acupuncture needles, you know? I can bring a woman a cup of tea, but I cannot diagnose, I cannot give her a drug, I cannot give her a pharmaceutical prescription. I can listen to what a woman needs, but I cannot uh, act like a clinician and perform some surgery.
Mm-hmm.
So yeah, very good question. Very not silly at all.
Thank you.
Yeah, absolutely. Thank you. And that's big shit, you guys. That's the big shit right there. That is, I would say, one of the biggest, that's the most important piece that I would love for to be shared is there is a clear distinction. It's okay that that's there. There are valuable bodies of knowledge within both forms, both paradigms. They are mutually beneficial to a woman's journey. She has rights to know and choose how she wishes. And as a worker, we have an opportunity to, you could look at just the extremes, to create a setting in which a woman can enjoy her chosen traditional birth process completely beside beyond the medical setting. She makes a series of informed decisions about her own management. She never chooses to integrate that care with the medical system. She doesn't feel she needs to. Everybody's great, doodly doo. And we can take that body of knowledge and go into the other extreme of a hospital setting, provide advocacy and awareness, not in the sense that we become a woman's voice, because technically everybody, you can't do that. That's just ridiculous. But that we encourage and support people to be making their informed choices and decisions about their care, their needs, their wishes, their wants. So those are that's the deal. Before we go, I would love to just quickly share what you found valuable. How is this valuable for you? How are you going to take this forward? How are you going to share it? I want to know. Jennifer.
Um, it just I've looked at your website and have read all this, but having you explain it this way really just gave so much clarity. And I know you know that like my husband has a lot of reservations, so having this information this way as a way to present it to him that it's okay and that there's safety in these regulations and they're there for a reason. And that's not what we're planning on doing here. Yeah, super, super helpful.
Amazing. I'm so happy, Jennifer. I hope he receives it. I hope him and many of our the men in our lives, you know, it's important for a lot of people, I think. Anybody else, the value that it's given you, the value that you're going to be able, how are you going to use it or share it with the people around you?
For me, like it really, for me, it really made it really clear that it comes down to the responsibility of the mother and the parents, whether they choose medical or whether they choose traditional. Like it, that really like, I mean, like I knew that before, but I feel like that was like really drilled in today that like that's what it comes down to, and that's really beautiful. I feel like I understand traditional work a lot better now.
Amazing, Amanda. Thank you. Thanks for sharing. Elise.
I think I came here today because I know all these things, but I think it's important in my work to always reset, right? In our community right now, you just always need to reset and just realign with your values and hear them and be in like-minded spaces so that we don't get lost, in things potentially that we could get, right? We could lose our way a little bit unless we always just review and have these conversations. So that's why I came today, was just to see you, Layla, and just hear you speak, and just to be in that space is really nice. So thank you.
Oh, I'm so honored, Elise. You are such an amazing birth support worker in our community. So I'm touched, deeply touched to see your face and hear your stories and share with you. Thank you. Anyone else? The value that you might take for yourself or for your communities, your clients?
I just love that you brought up about the choices of parents and how they really need to feel good about their decisions.
Mm.
You know, and another thing, when you mentioned our language and when we say need. And so just to be aware of that, um, and what, you know, the reflection of, if I'm saying need, why am I saying that? Right? Am I saying it because I want a certain outcome?
Thank you.
Mm-hmm.
It's so powerful to explore what we think need is, and it's powerful to explore that with our clients before they're in their birth setting. Ask them what they think needs. Ask them what their needs are, because need is really in the eye of the beholder, and that's. Thank you for bringing that forward. So important. Anyone else? So there were some other questions here which we won't be able to get to. Things like, would you offer the use of fetoscope and baby positioning checks? What about herbs and tinctures? The language about medicines, does that include traditional medicines? So these are fabulous questions, and it's 11. I said we were going to do an hour, and I want to honor and respect everyone's time. um, uh, I would love for you, I would encourage you each to get really into that 20-something page midwife regulation document. Sit down and read it. It's got definitions. It's got it, it's got words that are being used specifically. And look at the words that you're using, the understanding that you would like to, how you might behave, and think about how is a medical midwife behaving, and how can you behave that is distinct from that. So use that document to answer questions of whether or not you'd use a fetoscope. The word check, look at the word check. Think about what that means. What does that imply? Who's the boss there? Who's the manager there? Who's diagnosing or not diagnosing? Herbs and tinctures. Medicines, I'm interested too, Elise. I personally don't often use the word medicine about herbs and forest wisdom. But again, like reading that boring document and really getting into what, like, I'll say it because it's so boring, but it's so important. And Miss Dina, thank you so much for joining. I love that you're revealing your shyness. Totally appropriate and welcome. And thanks for coming. So to each of you, gratitude, warmth. I will share that what I found most valuable is that in such a short moment and in this sort of flash forum kind of way, that I feel like, and I hope that this is a service, and I'm okay with doing it once in a blue moon. So I will keep it at like this, as a flash for now. An intention that exists is to create a group setting of learning that is the program that I've created. Currently, I'm doing it with individuals because I just don't have enough people at one time. Everybody keeps popping up, and then another person pops up 2 months later. So until the moment arises when a group of people say, yep, we're going to do this all together, it's being offered privately. But I also really love this. So thank you each for sharing and for participating and just jumping in bravely and creating this kind of group discussion and setting. It's one thing to do it with one person, and then I see all these individual people that I speak with. It's another very great thing to show you, each of you. So if you'd like to get in touch with each other, email me and I will do some connecting if you feel called to stay connected. And yeah, I will be posting the recording. Please feel free to share. This is meant to be awareness and advocacy for the people. So give it to the people. Use it as a resource if you feel called. Yeah, do it. Oh, thanks, Madonna. She says private meetings with Layla has been a game changer for me. Yeah. So excited to see how our meeting next week, how your new clients are coming. Okay, so much love to each of you and enjoy this dark, dark season. Light all the lights and burn all the candles. And yeah, see you again soon.